Shavua Tov. It's a great Saturday night. I want to call everybody's attention. My wife made me say this, that tomorrow is Memorial Day, and the reason why we're able to sit here and in our synagogue and both daven during Shabbos and having these events is because we owe gratitude to many thousands and thousands of people who've fought to make sure that we could have this privilege. On a lighter note, the other reason why I'd like to thank you is because tonight we have a competition, and I've been told by many people that they would have loved to come tonight. It's actually a good thing that I didn't, but there is a comedy night at the Adapt tonight. So, and somebody actually over here, thanks to his wife always makes the best decisions, is here even though he had tickets for the comedy night. So this brings us to the age-old dilemma. What's more important? An open bar and humor, or education and my son the doctor, or my daughter the doctor? And from you guys, I think the answer is pretty clear. I don't know if anybody remembers Nikki Haley, our outgoing, our neighbor, friendly neighbors to the south, outgoing ambassador. And I don't know if people know at the Adapt, but I'll be taking names. I'm taking names of people who are there and not here tonight. So it's a great night. And we have a great lineup of people. This is really a unique event that we put together, which, to the best of my knowledge, hasn't been done elsewhere. But we're going to be combining medical students. Coincidentally, we had a Med 1, Med 2, Med 3, Med 4 from McGill, with some more senior people, some more senior than others. So they're going to be covering some very basic topics. The students are going to be presenting on very fundamental, basic concepts in cardiology, from prevention all the way to the state-of-the-art, cutting-edge stuff that Dr. Moss talked about his cool job on CJD. And then the more senior people are going to be talking about some of the cutting-edge concepts that cardiology, through the incredible innovation, many of which actually have occurred in Israel, how they can help us when we've gone beyond the prevention side and the basics. So there are going to be questions, time for questions in between each presentation and at the end of the talk also. I've asked people to limit the presentations to brief 5-minute, plus or minus 5-minute talks. And then we're going to take a couple questions in between each talk, and again, there'll be plenty of time at the end. And for those of you who don't know me, I'm Lawrence Rudsky. I'm in charge of the cardiology program and the Israeli Heart Center at the Jewish General Hospital. I've been there for 52 years. And everybody says I will be there for many, many, many more years. So I will be introducing each of the speakers, and I will be moderating the evening. Our first speaker, we have the honor of hearing from Eliana Sasher. Eliana is a third-year medical student, and she has been going to the synagogue for many, many, many years and has a very well-connected family in the synagogue. But that's not her claim to fame. Her claim to fame is that she is going to be a...
Ori's going first.
Ori's going first. Oh, your dad's here. Sorry, I didn't see that.
Yeah, I'm here.
Oh, so we're changing the order. We're going to go from the most sophisticated to the basic then. Which means that Uri Bender, Uri Bender has the privilege of presenting in front of his dad, Amiel Sasher. Sorry, Bender. It is the comedy night. So Uri's going to start off with really the end of what happens when our primary prevention and our basic medications don't work. He's going to cover a very basic topic, because a lot of my patients come to me and say, well, how come I can't have an angioplasty? Why do I need to have bypass surgery? So Uri's going to cover a little bit about why do some people get angioplasty where other people need bypass surgery, and then he's going to be followed by Manny Moss, who we'll introduce afterwards, who's going to talk about some cutting-edge cardiac surgery. Uri?
So hi everyone, my name is Uri. I'm a 4th-year medical student at McGill University. I see a lot of familiar faces here, and I'm sure a lot of people know my father, Emil, so I'm his son. I'm going to be talking to you today about CABG, or coronary artery bypass graft, or open heart surgery, versus PCI, which stands for percutaneous coronary intervention, also known as angioplasty, and what they are in general, which we use, and why we use them, in which situations. So first, before speaking about that, I think it's important to understand some fundamental aspects of human physiology and cardiac physiology. So the heart, you could picture it like it's a ball of muscle. Like, you hear me now? You hear me now?
Yes.
Okay, so first I think it's important to understand some basic physiology about the human body, essentially the cardiovascular system. So the heart itself is actually it's just a muscular ball. And the purpose of this muscular ball, like any other muscle, is actually to contract with the actual end outcome of pushing blood throughout the body. So blood is actually, this is vital to everyday life for multiple reasons. Primarily, I'm sure some people know that blood carries oxygen, and every single cell in our body requires oxygen in order to function. The blood also carries essential nutrients for all of our organs and cells, and it also removes waste. So every single cell in your body requires oxygen, and the heart is actually no different. So if you look at the heart, what supplies the heart with oxygen is actually these arteries called the coronary arteries. And that's a very important name because, which I'm sure many of you know, there's a disease called coronary artery disease. And that's what we're talking about when we're talking about surgery or angioplasty. So what coronary artery disease is if you could picture what a vessel looks like, and I have a picture later on that I'll show you, or I could show you actually now, go jump to it. Oh, sorry. There you go. So if you see, imagine this is a normal vessel without the metal thing in between. We'll come to that later. So what happens is you could get a plaque buildup, and the plaque builds up on the side of the vessel. So if you can imagine a vessel being a tube, if you get some plaque in the tube, it actually narrows the vessel a bit. And why this is important is that when the vessel is narrowed, it actually impairs the blood flow to the heart. So we get less blood flow, and the heart is essential to every organ in the body, and if the heart doesn't get blood flow, you could all imagine what could happen. So, how do we fix this? How do we fix it when we have these narrow arteries that are possibly impairing or will impair our actual cardiac function? So, first thing we could do that I'm going to speak about, which I'm sure many people are aware of, is open heart surgery, also known as coronary artery bypass graft, or CABG. And I put a little picture of a CABG because that's what makes it easier to remember. So, what we actually do in open heart surgery is, there are several techniques. There are some now newer, minimally invasive, which Dr. Moss will be speaking about. But for all intents and purposes, the open heart surgery, we actually open the chest and go in and fix the heart. What we're doing is we're taking a vein or an artery from somewhere else in the body, usually in the leg or from the actual chest wall itself. And what we do is, if you could imagine, like I was explaining before, this small little narrowed artery, we actually attach the vein from the leg or from the chest to a bigger artery and then attach it to the coronary artery that's diseased, but after the narrowing. So essentially, if you could look at this picture, if you could imagine there's a narrowing, for example, here, we're actually just bypassing the narrowing, hence the term bypass graft. And what that does is that restores blood flow to the actual artery that was impaired. So that heart muscle that's supplied by that artery will get the oxygen nutrients that it's requiring. We could do this once, we could do like single, double, multiple, depending on how many actual narrowings you have in your vessels and how many vessels are affected. Now this requires general anesthesia, so you're put to sleep. It's usually a longer recovery with a longer hospital stay. Now PCI, or angioplasty, is a minimally invasive technique that is used to achieve the same result as the coronary artery bypass graft, or the open heart surgery. And what we actually do in this one is, if you could see, this is the diseased vessel with the plaque on either side that's impeding the blood flow. We actually just take a catheter or a long metal guide wire. We make a small incision in the groin area under local anesthesia, and we trace through an artery in the leg all the way back up to the heart and to the artery in the heart that's affected. Once we're there, we actually inflate a balloon on this wire, and what it does is it opens the vessel, and then we put a stent that maintains the opening of the vessel, and this restores the blood flow. Now this is done under local anesthesia, generally a very small hospital stay, and a very speedy recovery. So now comes the question. Why would anyone ever want to do open heart surgery if you could just have this small angioplasty? And the answer to that is that actually depends. There's different indications for both. Now in the emergency setting, if someone has an acute emergency heart attack, generally we go for the angioplasty. It's a quick, you go in and you open up the artery and you restore blood flow to the heart before any of the heart muscle dies. But we also do angioplasty in patients that usually have one coronary artery that has narrowing in it. And if it's easy to access anatomically, peripherally, through the skin and through the vessels as we climb up. When we do open heart surgery, this is generally in patients that have multiple coronary artery disease. So, in all the arteries of the heart, there's actually multiple narrowings. Or if they're diabetics, and in diabetics we tend to see multiple vessel disease, so multiple coronary arteries affected. And we also tend to see more severe affecting of the arteries in diabetics. And then we can also do it in patients that have weaker hearts. We do the open heart surgery, and we also tend to do it in patients when we see that the artery that's affected actually supplies a large amount of the heart muscle. And the reason why we do open heart surgery in those cases is because the actual vein or artery that we put to bypass the narrowing is much more durable than the stent. So there's less reocclusion following, and it stays for a longer time. Now, I actually have a video for everyone if you would like to watch on how we do an angioplasty, the whole method, and it explains it with diagrams. Is there audio that's connected? I'll hold the microphone to see if it works. Is it connected? Okay, so sorry, it's not connected to the internet and we don't really have volume, but Dr. Eisenberg will be talking about angioplasty and he'll allow us to understand it a bit better. So thank you very much. I hope that that was clear.
Thank you, Ray. Bender. Our next speaker is Manny Moss. Manny is an assistant professor of surgery at the Jewish General Hospital. He's actually the training program director for the cardiac surgery program at McGill University. My condolences. He's also the Gross Teitelbaum Distinguished Scientist in Interventional Cardiac Surgery, and he's a mensch. And I know that because the way I was able to recruit him from the States back to Montreal was using the whole concept of tikkun olam and telling him not to go where it's best for him, but where he's going to make the biggest difference. So Maddie's made a great difference in Montreal and at the Jewish General Hospital. He's going to be talking to us about some of the cutting-edge techniques in robotic surgery.
Thanks, Lawrence. Yeah, actually, Lawrence did send me a lot of very nice emails before when I was deciding to come back to Montreal, and those kind of just stopped abruptly as soon as I said yes. I get out of this. So really it is a pleasure for me to be here tonight, and it's a lot of fun to see so many people here interested in everything that we have to say. Really I just have a few quick things to say, and I do have some videos in here. I tried to leave them as little blood as possible in case there's anybody that gets a little bit queasy in here, but if you do think you might get a little bit queasy, just either look away or let the person next to you know that they should keep an eye out for you. So kind of, first thing is, what's the difference between a cardiac surgeon and a cardiologist? I do sort of often get referred to as a cardiologist, and usually I let it slide, but there are some differences that are important. Cardiac surgeons generally do bypass surgery, we fix valves, we fix aortas, and we can do heart transplants. We do often have a reputation of being quite arrogant. Cardiologists, on the other hand, they do echocardiography, they adjust heart medications, they're experts at that, do that much better than I can. They put in stents and do angioplasty, like Dr. Eisenberg does, and in general, they're kind of nice, approachable people. So heart surgery really started back in 1953 when the heart-lung machine was invented, and since then it's looked kind of exactly the same. Like this guy over here with this big scar, you can't see my mouse up there, but scar in the middle of his chest. More recently, sort of back in the early 2000s and in the last 5 to 10 years, it's changed a lot. A lot of what we do, most of what we do still is what you see in the top left-hand corner there, but we do have newer fun techniques or interesting techniques that can get patients home faster and in a safer way. So what is the robot? I'll just sort of get right into that. The robot has two parts to it. There's a surgeon's console, which is when we sit in the corner of the room. We're able to sit at this, again, you can't see my mouse, but on the right-hand side of your screen, we can sit over there and we can manipulate the instruments that I'll show you in a second that are inside the patient. We get to look through this, sorry. Come on. I'm gonna have to switch over to my computer because I don't think any of these videos are gonna play. Just give me 1 sec, let's see if they will. Darn. Okay, sorry for a quick delay, everybody. Just give me 30 seconds here.
So while he's switching over, is anybody named Schwartz in the audience? No? Okay. So Mr. and Mrs. Schwartz go to their doctor. They have their annual checkup, and they're doing great. The doctor says to them, I wish you both this 120. So Mr. Schwartz goes to the doctor and says, can I speak to you for a minute? Sure. I want 118. What do you mean? There's 120. I want 2 years on my own.
All right, give us 1 second. Thank you for that, Lawrence. Well played. So again, what it looks like to me as I'm sitting at the robotic console is I have these two eyes in there, one for the left eye, one for the right eye, and it gives me 3D vision, and I can magnify things 10 times or more in order to really see well what I'm doing inside the patient. And so again, the camera actually has two cameras on it, one for the left eye, one for the right eye, and whatever I do with my hands on this console over here, you're going to see done in the patient afterward. This is what it looks like, that this big sort of octopus-looking or spider-looking thing next to the patient. These big robotic arms that sort of funnel down into these very small 8 millimeter tubes or holes that we can put in the patient. These robotic arms are what's moving outside the patient, and inside the patient you'll see in a brief moment. So it's actually kind of a big, cumbersome setup on the outside, but it does allow us to do complex surgery through very small incisions. So what can we do with the robot in heart surgery at least? So the two things that we do at the Jewish General Hospital, and really what's done worldwide, number one is bypass surgery. So we're able to, like where I was saying, instead of going through the chest and doing a sternotomy, or as they say, cracking the chest open, we're able to make 3 small incisions on the left side of the chest and do a bypass surgery through those small holes. And often we'll actually make another small incision just to actually sew the bypass on by hand, because for now I think we're still a little bit better doing that by hand than with the robot. The other things that we can do are things inside the heart. So this is actually technically, it's open heart surgery, but closed chest surgery, I guess you would call it. Sometimes people come into my office thinking it's not a big deal, just do a robotic surgery, but really still is a big surgery. So I do remind them it is open heart surgery, even if it's through small holes. So we can repair the different kinds of valves in the heart. There's the mitral valve, which I'll show you some video of after. There are a couple other valves as well. We can repair holes in the heart that patients are born with or develop over time. Or actually tumors in the heart also, we're able to take those out and repair things with the robot. You can't see the top there, I guess, but the question is really, why do we do this, or how does it benefit people? So there's 2 benefits to the robot. One is a benefit to the patient. Sorry if everybody over there can't see. Maybe I'll step back a little bit. I don't know if that helps. It's a minimally invasive procedure, but what does that really mean? Patients can recover faster. They can really get back to normal activity within 3 to 4 weeks after the surgery, because we're not, although we're making small incisions, we're actually not disturbing the skeleton at all. So there's no bones that need to heal up, and really what I tell patients after is, as far as what they're allowed to do after surgery, I tell them if it hurts, you might not want to do it, but you really can't undo anything that we've done, which is obviously very different from after you've gone through the breastbone and you need about 8 to 12 weeks for that bone to heal up adequately. Patients end up in the hospital for a little bit less time, as opposed to staying in the hospital for 5 to 7 days or longer. We can often get patients out within 2 to 3 days after surgery. The average is probably 3 or 4. And there's lower risk of certain complications. Patients end up staying on the ventilator, on the breathing machine for less time, less risk of needing some blood transfusions and other things along the way. So there definitely are some clear advantages for the patient. How does it help the surgeon? So as you'll see in a moment, so number one, really, we can see a lot better. Like I said, I have three-dimensional vision, and I can see the valve a lot clearer actually than when I can when I'm working through the front of the chest, and because it's magnified in high definition. The other thing is it actually gives me better dexterity. Our wrists can only move in a certain, or we call them degrees of freedom. The robotic wrists actually can do as much as our hands do and then do even more. And also, they're very precise. I can actually, tell the robot, if I move my hand 3 centimeters, only move 1 centimeter inside the patient, so it can actually make things very precise. And if you do have any sort of tremor, it actually knows the frequency of the human tremor, and it can filter that out, so you look a lot more steady. I've heard some surgeons that think about that as they near retirement. That's one of the reasons they took up robotic surgery. They've said that. So here's 2 quick videos. The first one is about robotic bypass surgery. Again, if anybody thinks they might be a little bit queasy, just look away, but it shouldn't be too bad. I ran it through my wife before, and she was okay. So this is what it looks like on the outside of the patient. There's those 3 small cannulas that are on the left side of the patient. We can put these small, this is obviously magnified, those are actually only about 8 millimeters that go inside the patient. We're inside the left chest here actually, the left lung is deflated, and we're just working on right behind the ribs there on the front of the chest to find this artery that we're going to prepare and use for bypass. I don't know if you can see, it's this artery right over here that we're using the robotic arms to take it off the chest wall and prepare to use to put on the heart afterward. And we go along this, and then we've actually opened up the sac around the heart, they're called the pericardium, in order to get access to the heart, and you see that beating behind under there. And there, right on top there is an artery that we're going to be doing the bypass on. Here we bring in another instrument to put a clip on the artery inside the chest, and then we're going to cut the end of that so that we can actually we're going to sew this onto the heart afterward once we're ready to do that. Everybody's okay so far? And then, so in this case, we actually made a small incision on the front of the chest to go between the ribs without actually having to spread them, and then we're going to, you see the heart beating through that small incision over there, and then we're going to end up sewing that, I'll show you in a moment, sewing the artery onto the heart in order to have a functional bypass. And there you see the suture going through that artery, and that artery is about 1.5 millimeters, 2 millimeters. When we're doing this, we're wearing magnifying lenses or loops that magnify things 3.5 times. And that's an angiogram that I guess Dr. Eisenberg will show you after, but after showing that the bypass is actually working and giving proper blood flow to the heart. And these are what some of those incisions look like in the patients afterward. Cut me off already? Technical difficulties. So then just very quickly, this is only about 1.5 minutes, for robotic valve surgery. So this is actually going inside the heart, stopping the heart using the heart-lung machine, and emptying it out in order to fix the valve. So here you see us just making our incision into the heart, and then we're getting exposure, opening up what we call the left atrium, which is the upper chamber of the heart. And then we're going to get access to the mitral valve, which is the most common valve that we have to fix. And this is a valve that's sort of like 2 half parachutes that the strings on the parachutes can sometimes get a little bit long, so we need to go in there and either put new strings on or cut out a little piece of the parachute in order to fix it. So this is, again, we're now going even deeper into the heart to put those new strings on, which are actually made out of Cortex, like the stuff you have in raincoats. You see the robotic arms there putting that suture first through the muscle of the heart and then through that valve in order to pull that back down into the heart so the valve's not going to be leaking afterward. Then we always put this little band on afterward in order to cinch things down a little bit because the opening of the valve does tend to get a little bit stretched out. So we just want to bring things back together. Let's see if I can skip a little bit. And then we end up testing the valve after, and you can see now it's actually We're putting a lot of saline into the heart in order to see that it's working properly and the valve's not leaking anymore. This is what it looks like right after the surgery, and there's just a couple photos here, what it looks like a little bit later. That's about a week after surgery, and this is about 6 months after surgery probably. And this is a happy customer. So that was just what I want to show you briefly. If there are any, I guess we can take some questions now for either me or Ori. 1 or 2 questions, and then if we don't get to you now, then try and hang out to those, and we'll address them at the end of the evening.
I'm wondering what sort of experience you've had or what you know about repair of a repair. In other words, if you have a first repair, and do robotic surgery on the second time to do sort of fix the repair, even if there's a ring in place.
Yeah, no, it's a great question. The answer is yes, it can be done. The answer is it can't always be done for every patient. It really depends, when you're coming back and you've had one repair already and it's failed, the question is why has it failed, and is it fixable, or is it sort of, you need to now go ahead and replace the valve. But if the valve is not fixable, then we can actually replace the valve also using the robot, using similar techniques. Yeah, go ahead.
Are there any disadvantages to the robotic surgery as opposed to the traditional method?
Yeah, there are. I think it's like any surgery, it's user dependent. So you need to have proper training in using the robot and proper experience in order to do it safely. That being, on top of that, it's not just the surgeon that needs experience. The team around the surgeon needs a lot of experience. Needs to be very well trained. So if you're working in a setting that doesn't have that proper experience, then you can actually, you're not necessarily doing the patient a favor by working through smaller incisions. There are other, initially it does take a little bit longer to do these surgeries using the robot versus doing it through the front. Again, because people are just more comfortable with that traditional technique. And it's not applicable to everybody, but in general, a patient who, is an appropriate candidate for robotic surgery, I think there are more advantages than disadvantages, clearly.
That's what my administrators had on. So from an administrator's perspective, disadvantage is it's an extra $10,000 to $12,000 for the supplies for the surgery for the robot. So that's...
From the hospital administrator's point of view, also there are savings after the surgery, getting patients home sooner. And him in Quebec likes us too, because they use less blood transfusions.
But really, at the Jewish General Hospital, our initial first-line strategy for every mitral valve repair is robotic. Last question.
Can you do it from a different location? In other words, can the surgery be done in northern Quebec using the robotic and you be?
Again, the quick answer to that is yes. The longer answer is I wouldn't recommend it. So the robot actually it's been used to do surgery across an ocean, and it was actually initially the robot was initially designed to be used on the battlefield, so that the robot can go out there and the surgeon can stay somewhere safer and do surgery. But really, it takes a very experienced team in order to do the robot use the robot at the bedside. And also, if there's ever any issue, you kind of want your heart surgeon in the room with you if there is something that needs to be taken care of. So it can be done, but in general, it's not.
Okay, we're going to go back to our first speaker. Thank you very much. That was great. Anna, who has already been introduced, is going to be talking about some very, very basic but still controversial concept of who should be taking aspirin, who should be taking a cholesterol pill.
Hi, my name is Aliana Sasha. I'm a third-year medical student, and today I'll be talking about who should be taking an aspirin or a cholesterol pill. Sorry. Hello? Okay, so to start off, what is aspirin? And aspirin is a medication that prevents clots from forming in the arteries of your heart. And as Ori mentioned, around the heart there are coronary arteries. And normally these arteries should be clear, kind of like long empty tubes that bring blood flow to the heart. Because like all vital organs in your body, your heart needs blood to function correctly. And over time, sometimes with heart disease, you start to have clots forming in these arteries, and that impedes blood flow and makes your heart not work as it should. And aspirin actually prevents this process and prevents clots from forming in the arteries of your heart. And therefore, it reduces the risk of developing heart disease. So having said that, who should be taking an aspirin? Well, it's been well established that everyone that has heart disease, that's been diagnosed with heart disease, should be on an aspirin pill. And the question more comes into concern with people who are not yet diagnosed with aspirin and whether or not there's some sort of preventative benefit of them being on an aspirin pill. So we could look at this in two different populations. First, we could look at adults over the age of 50. And recently it's been shown that if you're a healthy adult over the age of 50 and you have a low risk of developing heart disease, there's really no need to be on an aspirin pill. However, if you're above the age of 50 and you have a high risk of developing heart disease, you should be on an aspirin. And I'll talk about how you decide if you have a high risk of heart disease in just a moment. And finally, if you're below the age of 50, there's really no need to be on an aspirin unless you have some sort of exceptionally high risk or other exceptional circumstance. So, how can you estimate your risk of heart disease? It's not one factor, but in fact a combination of many different factors that determine one's individualized risk. And these factors include whether or not you're a smoker, if you've been diagnosed with diabetes or not, how old you are, what the cholesterol level is in your blood, as well as your blood pressure. So all of these factors combined determines one's inherent individualized risk. And in fact, there are calculators out there that use all of these values. You can input all these values and decide what your risk of developing heart disease would be in the future. And in fact, your doctor might use these sort of calculators when deciding whether or not you belong on an aspirin pill. So just like many medication, aspirin does have side effects. And the main side effect of aspirin is bleeding. And how does this make sense? Well, in the first slide I mentioned that aspirin prevents clots from forming in the arteries of your heart. However, clots forming in different blood vessels across your body is normal. For example, if you fall, you have a cut, you have a bit of bleeding at the beginning, but then over time the bleeding stops. And this is because all the vessels that were bleeding have clots forming over them, preventing further blood loss. So if you take a look at the first image with no aspirin and you have a damaged blood vessel, a clot forms over the damaged part of the vessel and there's no really ongoing consequences. However, if you are on an aspirin pill, the damaged vessel stays damaged longer and you might have some ongoing blood loss. And that's why the main side effect of aspirin is bleeding, and most importantly, bleeding in your stomach and intestines. So what about cholesterol pills? What are they? So they're collectively referred to as statins. And statins decrease the amount of bad cholesterol in your blood and therefore lower your risk of heart disease. So you could think of the cholesterol in your blood as the total amount of cholesterol. And this is further subdivided into two different types. You have HDL, which is the good cholesterol, and that's protective against heart disease. And then you have LDL, which is bad cholesterol, and that's the cholesterol that kind of promotes heart disease. So not only do statins decrease cholesterol, but they inherently decrease the bad cholesterol in your blood. So having said that, who should be on a statin? Well, if you have heart disease, just like with aspirin, you should be on a statin as well. However, if you don't have heart disease and have a high risk of developing heart disease, as I mentioned earlier, you should also be on a statin, as it is protective. And if you have a low risk of developing heart disease, there's really no need to be on a statin. And the main side effects of statins include mainly muscle aches and pains. So in summary, aspirin and statins are medications that should only be used when you have a valid reason to use them. The decision to take an aspirin and statin is highly individualized, and when used correctly, aspirin and statins can greatly reduce the risk of developing heart disease. Thank you.
That was very great. It was very, very straightforward. I think everybody understood that. We're going to introduce our next speaker, my colleague Mark Eisenberg. Mark actually has been on staff at the Jewish for over 20 years. I was just about a resident when he started on staff. He's a professor of medicine at McGill University. He directs the MD PhD program at McGill University, internationally recognized epidemiologist, and he's going to be talking about one of his clinical specialty, which is interventional cardiology, some of the latest updates.
Zach. Good. Okay, can everybody see? Everybody hear me? Yeah? Oh, we got a mic here too. Perfect. Yeah, good.
shaped like a mouse.
I see. Okay. Good. Okay. So Lawrence gave me a topic. I can't remember what it was, but I changed it. And in view of the weather, I changed it to Cath Lab Whirlwind. So I'm going to give you a little whirlwind tour of what the Cath Lab is. It's the cardiac catheterization laboratory where I work. And a catheter is a long tube, about 2 to 3 feet long. And Manny, we were the original minimally invasive, interventional people. This is a picture. This is not our cath lab, but I don't have one of myself. But our cath lab looks very similar to this. So it's like an operating room. There's a big C-arm. There's a radiation source on the bottom, and there's a camera on top. And we have to wear big lead vests and leaded glasses, you can see, to protect ourselves from the radiation. So we all get back problems after a few years. Okay, so this is just a schematic of the vascular system in the body, and you can see that we used to. I don't know this, Lawrence. I don't think this pointer is working too well, but we used to go through the groin, all of our procedures.
Just for you. I tried to. This is actually a normal.
Ah, okay.
That was a mouse too, because you're.
Okay, so we used to go through the groin for pretty much all our procedures and put a catheter into the femoral artery and put it up to the heart. Now about probably 90% of our procedures are through the radial artery, so that's the artery where you feel your pulse in the wrist. Okay? And this is a schematic of the heart. I think I couldn't see from over there, but I think you already showed one of these. But so this is the heart, and we deal with all the structures in the heart. This is the outside, and in the red arteries are the coronary arteries. So this is the right coronary artery, left anterior descending and circumflex artery. So in the old days, we used to say the patient had a massive coronary. I don't know if you remember those days. So that's when one of those gets blocked at 3 o'clock in the morning, and my team and myself, we have to come in and within 20 minutes or so and open that up. And every minute that it's not open, the muscle is dying. Besides that, you can see the aorta, which is the main artery that brings blood out of the heart. And on the right side, you see the opened up part, and you recall probably from school, there's 4 chambers in the heart. There's the left ventricle, which is the main pumping chamber, the left atrium, right ventricle, right atrium, and then there's 4 valves. So there's the mitral valve, the aortic valve, tricuspid valve, and pulmonary valve. So we're going from either from the radial artery or from the femoral artery to go up into all those different structures. So, this is not projecting at all. Okay. Jack, I can't show any of my pictures. All right, Lawrence, you're going to need another joke now.
Okay. I can't think that this was actually an old Jackie Mason joke. People always complain about not being able to see their doctor. So you have 4 Jewish guys, who they're comparing. I have the best doctor in the world. My doctor, I have to call a whole month in advance to get an appointment with him. The guy says, no. My doctor, I have to call 3 months in advance. That's good. The other guy says, no, I have to book a year in advance to see my doctor. So the last guy says, no, your doctors are all amateurs. My doctor is so good, nobody's ever seen him.
Perfect timing. That was great. Okay, so I decided, I think Lawrence wanted me to show the high-tech stuff that we do in the lab, but it's a little, it's difficult to show. Instead, I thought I'd show some cases. Nobody in this room, okay? So you can see here, this is a catheter coming up from the femoral artery, and it's in the aorta. And this is called a pigtail catheter. It looks like a pigtail in the left ventricle. So this is in the left ventricle. You can't see the blood in the heart, so we have to inject contrast or iodine. So we're injecting iodine into the left ventricle. It's squeezing very nicely. You can see the left ventricle is squeezing nicely, but unfortunately a lot of the blood is going backwards into the left atrium. You see that structure filling up over there? And that is severe, what's called severe mitral regurgitation. That means that the valve connecting the left atrium and the left ventricle is wide open. All the blood's going backwards, and that's going to give you pulmonary edema, shortness of breath. So this was a ventriculogram, what we call it, before the patient went for surgery to have that valve replaced. I also like you to notice the aorta here. You see that nice, nice, smooth, narrow aorta, and this well-functioning left ventricle, because we're going to show a couple of pictures of malfunctioning ones. So this is a patient with what's called Takotsubo syndrome. You might have heard about it. It's called the broken heart syndrome. This is if somebody gets a big fright, if somebody comes and tells you that someone in your family died or something terrible happens. Oftentimes people can have what looks like a heart attack. They can collapse, and they can die from this. And what it is it's like an overdose of your own adrenaline, and it paralyzes the left ventricle. So you see the left ventricle here, it's hardly moving. You see that? The base of the heart is moving, but the left ventricle is paralyzed. And in fact, it's working so poorly, there's actually a little bit of blood clot in the tip there. So patients can be very, very sick. It looks like a heart attack. We inject dye in the coronary arteries, but the coronaries are normal. And what we do in our CCU is keep people alive for a few days, and actually this goes back to normal within a few weeks. The left ventricle goes back to normal if you can keep them alive. So that's the broken heart syndrome. Next is the pigtail in the left, the ascending aorta. Remember I showed you that nice narrow aorta before? This is called an aortic aneurysm. This is a huge aneurysm of the ascending aorta right here. And if that ruptures, you're dead. So we need to identify that and send patients for surgery. And in fact, this person, you can see that the aortic valve is leaking, so some of the dye is going into the left ventricle. So this patient needs a replacement of the aortic valve and a reconstruction of their ascending aorta. So this is like a time bomb in your chest that we have to identify. So that's what cardiologists do, identify things like that. Okay, so angioplasty, this is what we spend a lot of time doing. This is a catheter in the right coronary artery, and you can see a tight blockage here. Everybody see that, tight blockage? And there should be a big, big artery coming down here, but it's completely blocked, very tight blockage right here. And we go down and thread a wire across it. It can sometimes be quite difficult. It might take an hour and a half to do this sometimes. We get a wire down into the distal artery, and then we used a balloon with a stent on it. I'm cutting out a lot of steps. This stent is 38 millimeters long and about 3 millimeters wide. So we deliver a stent, and then we collapse the balloon and take it out. And this is what it looks like afterwards. So there's a huge artery here that was completely blocked. So when you have that, you're going to have angina. If it closes suddenly, you have a big heart attack. This is a bypass. This is a bypass from the vein from the leg, and if they get to be 10 years out, they can get blocked. I don't know if you can see it, but there's a lot of clot in this bypass right down here. I don't know if people can see that. So what we do is we suck out the clot with a catheter, and then we put a stent in there. And this is what it looks like afterwards. It looks good. And this is actually the clot that we suck out in the catheter.
I didn't show any of your failures.
We're a hard team approach. This is the last one I want to show. Okay, this is right coronary artery, nice and big and smooth. Everybody see that? That big artery there coming down? But the artery is actually feeding a big tumor in the left atrium. I don't know if you can see that. It looks like a golf ball filling late right now. Everybody see that? Okay, so this was what's called a left atrial myxoma. We were doing this, and the patient went to surgery the next day. So here's the. It's going to play it. Let's see here. There we go. So this is, we don't do this. This is what Manny does. Takes out the myxoma. This wasn't one of your cases. So there it is, coming out. And that's the size of it. So you can see it's about 7 centimeters, that tumor that was in the heart. So we really work very closely with the cardiac surgeons and the cardiologists. We do a lot of the diagnosis and taking care of the patients. We send them for surgery. We go back and forth. So that's what we do. Okay, thanks very much.
People have questions for Eliana or Dr. Eisenberg. While we're waiting, just a quick question for Rabbi Spurman in the corner. We read recently about the first case of broken heart syndrome or Takotsubo during the Torah reading. Do you know who was probably the first victim of Takotsubo? We just read in Chayei Sarah, when Sarah got very bad news, she suddenly died, right? At the ripe young age of 127. That's probably the first case of Takotsubo. Any questions? First documented. We can do a case series, we can do Eli Cohen also, but there have been a number described. No questions? So then we're going to go on to our next group. We're going to have more time for questions at the end. So the next speaker, someone who I've known for a few years. His name is Jack Redsky. He's a first-year medical student at McGill, and he's going to be talking about we're going to switch away from the coronaries to some electricity. You know, we have plumbers. The heart has valves, and it has pipes, and it has a pump. And so we also has wiring. So we're going to talk about some electricity, and so Jack's going to be talking about atrial fibrillation, who needs a blood thinner, and which one.
So hi everyone, Erev Tov, Shavua Tov. I'm Jack. I'm the baby of the group. I'm the first year medical student. And I'm going to talk to you about who needs a blood thinner for atrial fibrillation. So I think we should start by talking about what atrial fibrillation is. So on the right, we have a normal heart. So the electricity that causes a heartbeat starts near the right atrium in what's called the sinus node. And it moves through the two atria to another node, which is called the atrioventricular node, or the AV node. And then it propagates through the ventricles, which actually pump the blood out. Now in atrial fibrillation, you don't have that organized electrical activity in the atria. So you have a lot of high-speed, what are known as high-speed reentrant wavelets, going at like 400 to 600 beats per minute, which is way too fast. And thankfully, the AV node here filters them out so that the ventricles can still pump at around 150 beats per minute, and you can still have blood flow to your body. So even though the ventricles are pumping properly, there's still a problem with the atria. And so because the atria aren't really contracting, they're kind of fibrillating in a way, you can have abnormal blood flow. So abnormal blood flow is one of the potential causes, is one of the factors that can contribute to a blood clot. And if you have a blood clot in your heart, it can travel. It won't necessarily travel to the coronary arteries. It may travel to the brain and give you a stroke, which is not very good. And that can happen in atrial fibrillation because the blood in the atria isn't moving properly. So there are some patients with atrial fibrillation who are more at risk of stroke. And as doctors, we're kind of simple, so we like having risk scores. So there are a bunch of risk factors. So if the heart function isn't very good, they're at a higher risk. If they have high blood pressure, if they are above age 65, if they have diabetes, if they've had a previous history of stroke or vascular disease. So all of these are put together into what's known as the CHADS VASC score. And the more factors you have, the more at risk you are of having a stroke. So on the low end, if you don't have very many risk factors, you have a very low chance of stroke. So if you only have one of them, you're at about 1% chance of having a stroke per year. But if you have like 7, 8, or 9, you're running around 10% or higher. So it's really a problem. So what can we do to decrease the risk and to prevent stroke? So to form a blood clot, there are a lot of proteins that are involved. So 4 of them, so factors 2, 7, 9, and 10. You guys don't need to know the names. We do. You don't.
Not on the exam.
Not on the exam. You will not be testing on this. So those are so the function of those proteins is actually dependent on vitamin K. So the classical way of preventing blood clot is to give someone what's known as a vitamin K antagonist. So the most well-known of them is warfarin or Coumadin. So that prevents the proteins from functioning properly, and you don't get a clot. So Coumadin, we've used it for a long time. We know how it works, its ins, its outs, and it's cheap. But it does have several disadvantages. So you have to be very careful with what you eat when you're on Coumadin, because you can't have very much vitamin K, because then it interferes with its competition with vitamin K. So you can't have broccoli, you can't have Brussels sprouts, you can't have kale, or many other leafy greens. Ironically, the stuff that your doctors actually tell you that you should be taking. So there are also other disadvantages. So you need to have blood tests to make sure that your blood isn't too thick or too thin. So you're in the Coumadin clinic a lot. You're also at a high risk of bleeding because you're targeting so many clotting proteins. So more recently, they came out with what are known as novel oral anticoagulants, or also known as direct oral anticoagulants. Now these only target one protein in the whole load of proteins that are involved in forming a blood clot. So there's one that targets thrombin down here, which is called dabigatran or Pradaxa. And you also have two that target factor 10, a protein known as factor 10 up here, which are apixaban and rivaroxaban. Now, if any of you have watched American television, you've probably seen advertisements for them. So these agents are much more selective. So because they're only targeting one protein, you have a decreased bleeding risk, which is really good. You don't need to have blood tests to monitor how thick or thin your blood is. You don't need to worry about your vitamin K intake, so it's really much easier on the lifestyle. But unfortunately, these new drugs, even though they're great, they shouldn't be used in patients who have mechanical artificial valves, in patients who have narrowed mitral valves, and patients with serious liver or kidney disease. So now to answer the big question. So who gets a blood thinner for atrial fibrillation? So I took the 2016 Canadian guidelines. There's actually a 2018 version, but I was too slow for it. So everyone above age 65, they should be on a blood thinner, and preferably one of the newer ones. But even if you're not over 65, there are some patients who still should be having blood thinners. So if you have any of the risk factors, so like if you have diabetes, if you have hypertension, if you've had a previous stroke. And then other patients don't really need a blood thinner. So now, who still should have Coumadin over the newer drugs? So patients with mechanical valve replacements, and patients with mitral valve stenosis, or which is also known as a narrowing of the mitral valve. So that's about all for me. I will now cede to Dr. Natel, who actually I had the privilege of learning this material from this week.
A little clarification, when Jack at the end was saying who should take a blood thinner, this is in the context of atrial fibrillation, just to make it 100% clear. Dr. Natel is very well known both in this congregation and in the city and around the world. He is an internationally recognized researcher in the field of atrial fibrillation. He's also in charge of the electrophysiology research axis at the Montreal Heart Institute. He's the editor-in-chief of the Canadian Journal of Cardiology, and just last month I saw in Toronto where he won the annual achievement award of the Canadian Association of Electrophysiologists. So it's really a privilege to have him. And also, 30 years ago, he taught me my cardiac pharmacology, which I still remember very well, which is a tribute to how great a teacher he is.
I'm a good teacher, but I'm having trouble getting a computer to recognize my USB.
30 years ago was
okay.
overhead.
That's right. You only have an HDMI because I have an adapter. But
we have a VGA, but we have to move it closer.
Well, I don't know. It's not somehow it's not reading my USB yet. You got it. Wow. Oh wait. Like this. Well, Well, if you have a standard, I have HDMI and I have an yeah, I'm doing it.
So I may think that I'm funny, but in all honesty, I remember I had this little lady in my office, this little lady for lunch. I'm telling her one of these jokes, usually the punchline is, "You're too tense." She says to me, "You know, Dr. Vatsky, maybe we should think about being a doctor."
That was it? Yeah, there we go. All right. Whoops. There we go. Okay.
Okay, thank you very much. Sorry for the technical glitches. All right. So, it's up there, it's fine. Okay, so what I'm trying to do today then is very simply to explain some of the main aspects of what atrial fibrillation is, and since I was asked to talk about new things, I'll spend a couple of minutes talking about some newer treatments that might be relevant for some of you. So Jack has spoken in detail and appropriately about clots that happen in the atrial appendage. So that's one of the big problems from atrial fibrillation. Atrial fibrillation can also impair heart function and cause heart failure, which is not a good thing. And it can cause an impaired quality of life from the symptoms from fast heartbeats, impaired heart function, low blood pressure, dizziness, and I leave it up to you to guess which of these people have the impaired quality of life here. So then the question is, what should someone who has atrial fibrillation, which is usually abbreviated AF, because it's a lot faster to say than atrial fibrillation, so what should people who have AF worry about? So the three main risks are risk of stroke, risk of heart failure, and uncomfortable and disruptive symptoms. So as far as risk of stroke is concerned, we can basically put that aside with Jack's presentation because anticoagulants are extremely effective, the new ones are safe, and if people take them, they do have to take them and take them at the right time, but if they take them, they don't have to worry about an increased risk of stroke. The second risk is the risk of heart failure, and this can be managed by either preventing AF or controlling the rate, more about that in a moment. But basically, as long as the heart rate is not too fast in atrial fibrillation, that is at least 120 beats per minute for weeks or months, the risk is controlled. So you don't have to worry. If you have atrial fibrillation and your heart rate is fine, you don't have to worry you're going to get heart failure. The final issue is the uncomfortable and potentially disruptive symptoms, and to manage that, you really need a patient-based approach, and I'll talk a little more about that in a minute. So there are basically two approaches to therapy. As Jack mentioned, atrial fibrillation is from a very fast rhythm in the top parts of the heart, the atrium. They get filtered out in a structure called the AV node, through which the cardiac impulse has to go down to the ventricles, which is the pumping part of the heart. So although the atria are firing at 400 to 600 beats per minute, the heart rate is determined by AV node filtering, and if the heart rate is okay, the patient is often okay. They often have no symptoms and they feel fine. The second approach to therapy is to restore and maintain normal rhythm. Now it sounds like, well, why don't we do that in anybody? Well, we can accomplish it in anybody, or almost anybody, with a controlled electrical shock. So that's great, the heart goes back to a normal rhythm. The problem is that the arrhythmia often comes back. And after restoring a normal rhythm, in something like 25 to 50% of people, the fibrillation will come back in anywhere from 6 months to a year, and in others it'll come back later on. So that's the problem. It's not hard to get people into a normal rhythm. The hard thing is to keep them there. Drugs can be used to prevent going back into atrial fibrillation, but they're only moderately effective and they have risks of side effects. Now, before I go on to the new and fancy treatments, I want to emphasize one thing, and that is that there have been many studies, well-designed studies, to see when patients do better, whether they're left in atrial fibrillation and just kept from going too fast, or whether the rhythm is controlled. And the bottom line is, in a large population, there's no difference between the two. So that's why it's really a patient-based approach, depending on what the patient feels better with and so forth. So some new approaches to maintaining normal rhythm. I mentioned drugs aren't that good. There are new approaches that have been introduced in the last 15 to 20 years and perfected, which involve burning the tissues from which the atrial fibrillation starts. So there's one technique which is very widely used that involves burning. There's another technique that was actually developed at the Montreal Heart Institute, where I work, which involves using a cryo balloon to freeze parts of the atria to get rid of these zones. So this is called ablation, and it's very useful if drugs fail and the goal is normal rhythm. It works about 70% of the time in selected patients, so it doesn't always work, but if it fails, it can be redone. So this is definitely an option if necessary. The second new thing in atrial fibrillation is new approaches to controlling stroke risk. What about patients who have AF but can't take anticoagulants because of bleeding problems? My wife is in the audience. She has a patient who had recurring bleeding from her stomach, but she also had atrial fibrillation with a very high risk of stroke. So what do? Do you put her on blood thinners and risk killing her by bleeding, or you not put her on blood thinners and risk her having a debilitating stroke? Not a very appetizing set of choices. So one of the things that we can do now is put in a device. There are several different ones. This is the most commonly used one, called the Watchman, which goes into and blocks up this part of the atria where the clots tend to come from, called the atrial appendage, and prevents strokes from happening. So it's not a panacea. It's not a replacement in general for anticoagulants, but for people who can take them and have a high risk of stroke, it can be very helpful. I'm going to finish by talking about a point that I think is very important, and that is that atrial fibrillation is a major cause of stroke. It's the most important cause of stroke in the elderly. It is present in about 15 to 20% of people over 80 years old, and sometimes it presents with debilitating strokes. So the first time you know somebody has atrial fibrillation is when they come in with a terrible stroke. So there's been a lot of efforts to pick it up early, and in patients, either in asymptomatic patients who have no symptoms, or in people who have symptoms but we don't know what they are. And there's some interesting new approaches to diagnose it, which are fairly straightforward. One is a device called a Cardia, which can be used with a standard iPhone or Android. And you just put 2 fingers on it, it records the 25-second ECG. So if somebody has symptoms that they think might be that, they could actually do an ECG and send it to their doctor, and I actually recommend this for those of my patients who want to try to do this. The Apple Watch is being developed one of the apps is being developed to actually detect atrial fibrillation on the newest Apple Watches. Now, I don't know about the reliability and sensitivity, specificity. It's just been developed, but it's potentially interesting. The last thing that almost everybody can do is use an electronic blood pressure cuff. You'll notice it gives you 3 numbers. 2 of them are your blood pressure, the higher and the lower number, but it also gives you your heart rate. So if your heart, and it tells you if it's regular or irregular often. So if your heart is irregular and it's going over 100 beats per minute, you should see your doctor, because it could be atrial fibrillation. So thank you for your attention, and questions will come later, I guess.
A couple of minutes for some questions now on atrial fibrillation.
What about ventricular fibrillation?
What about ventricular fibrillation? So ventricular fibrillation is not subtle to diagnose. It causes sudden cardiac death. I guess for this audience, one very important aspect to be aware of with respect to ventricular fibrillation is that you have to restore, so when the ventricles fibrillate, there's no cardiac output, and the brain will die within about 10 minutes, and within 5 minutes, irreversible brain damage happens. So you could say, okay, well, what do I need to know about that? Doctors need to know about that. But what you need to know about it is the outcome of resuscitations of people who have ventricular fibrillation, because resuscitation is possible. You can normalize the heart rhythm with a defibrillating shock, which is what the paramedics will do when they get there. But the outcome is largely determined by whether there's someone there who knows how to do CPR while you're waiting for the paramedics. So everyone in this room who is capable of it should learn to do basic CPR, because it could save somebody's life. So that's what I have to say about ventricular fibrillation.
I just wanted to ask, what's the treatment of choice for symptomatic PVC?
The question is, what is the treatment of choice for symptomatic PVCs? So, first of all, what are PVCs? They're extra beats from the ventricle. Generally, they have no risk. If they're symptomatic, so if they have no symptoms, you don't need to treat them. If they're symptomatic, then it's really a dialogue between the patient and the doctor. There's a whole range of potential treatments, from fairly innocuous drugs that won't hurt you but probably won't help you very much, through to drugs that may help you but may also hurt you, through to, at the extreme, if the PVCs are causing impaired heart function, which they can do if there's a ton of them, ablation of the PVC. So there's a whole range of things. But many people who have PVCs, these are just extra beats that make your heart feel funny, are symptomatic because they're scared to death about them. And I try with my patients who feel their PVCs to get them to understand that the risk of the PVCs is probably much less than any drug that will actually control them. So, but goes way beyond what we can discuss now.
I would just add also that some very basic things like decreasing your caffeine intake, decreasing your alcohol intake, and stress modification can also help in decreasing PVC burden. Other questions? Okay, I guess.
Several years ago, I had heard that drug companies were working on antidotes for the new generation of anticoagulants. Are any of these on the market? Are they still working on them, or are they just
Okay. So the question is relevant because the argument that people had for warfarin, which is this drug which was originally developed as a rat poison, by the way, and still used as a rat poison. So the argument that some people used to use it regularly was, well, there's no antidote to the newer anticoagulants, whereas for Coumadin or warfarin, you could reverse it with vitamin K or plasma or things like that. It's not really a very good argument, because warfarin causes a much higher incidence of bleeding in the head. And if you have a bleed in the head, the fact that you can reverse it after there's irreversible brain damage is not very satisfying. But in any case, for the newer anticoagulants, for those of you who are worried about it, the antidotes, one of the antidotes is now on the market, the one for dabigatran, and the other one, which will work for the other new anticoagulant, is in advanced stages of development and will probably be introduced soon. I have to say, I don't think that the antidote has, to my knowledge, ever been used at the Montreal Heart Institute, not because we don't know how or whatever, just because the situations where you really need it and want it are uncommon. They do happen. I'm not trying to poo-poo it completely. I'm just saying it's not such a big issue.
Our experience at the Jewish, as a general hospital, we do have instances where we do have to reverse with antidotes. The antidote to Pradax is actually available at every hospital in Quebec. The antidote to the other agents, which, as Dr. Tell said, is still under experimental protocols, is available as part of a research protocol, but only at the Jewish Hospital. Last question.
Is Plavix much better than aspirin?
Do you want to handle that?
Are you talking about
For atrial fibrillation or for coronary disease?
We know the name of the drug, but so the question was about Plavix, but do you mean Plavix for atrial fibrillation or for coronary disease?
For atrial fibrillation.
Okay, so let me say, neither Plavix nor aspirin by themselves have any significant effectiveness for atrial fibrillation. The combination has a little bit of effectiveness, but not as good as a standard anticoagulant, so I don't recommend it.
The
In
issue,
terms of TIAs,
TIA, that's something that other people are going to talk about, okay?
So in terms of TIAs, there's many causes for TIAs or stroke. We were focusing this evening on atrial fibrillation as a cause, because if you look for, as cardiologists, we look for cardiac source of embolization. But the concept of atherosclerosis that we see in coronary disease, if you think about the circulation, it's one continuous circuit. So you can have atherosclerosis anywhere. A lot of TIAs, most TIAs and most strokes are actually not related to the heart. They're related to the blood vessels in the neck or blood vessels anywhere else, or hypertension. So in that situation, if it's not atrial fibrillation, we don't treat it with anticoagulants. We do treat it with antiplatelet agents, aspirin, Plavix, sometimes the combination, especially for the first few weeks.
Can I explain something?
Yeah.
Okay, so just to explain, aspirin, there are two kinds of, general kinds of clotting in the blood. One is carried out by these clotting factors that warfarin, that Jack showed the picture of. Warfarin acts against them. The new oral anticoagulants do as well. That is one kind of clotting. Another kind of clotting is mediated by little blood cells. They're much smaller than red cells. They're called platelets. They're sticky little things that are kind of the first line of defense for high flow systems like arteries. So when we talk about blood clotting, there are basically two general kinds of blood thinners. One acts on low flow systems, like where the clotting factors are involved, like vein clots and atrial clots. For those, you need things that interfere with the clotting factors we talked about already, like warfarin or Coumadin, and the new oral anticoagulants like Eliquis, Pradaxa, those kinds of things, okay? The other kind of clotting that happens in arteries is mediated by platelets, and there you need aspirin or Plavix. So when you treat coronary artery disease, that's an artery problem, so you're talking about Plavix or aspirin. When you're trying to prevent strokes that are due to blood clots coming from the carotid arteries, the arteries that go to the brain, usually talking about Plavix or aspirin. When you're talking about strokes in relationship to atrial fibrillation, you're talking about the oral anticoagulant. So those are the different kinds of categories, and depending on the clinical situation and what you're trying to prevent, you might need to use one or the other.
Thanks, Stan. So we're coming to our last group of speakers. Before I introduce our next speaker, who's Alexandra Cohen, I want to actually acknowledge her father, Mike Cohen, who is one of our city councilors for Coast St. Luke, who was the inspiration in putting together this evening. He worked through Judah Aspler and Jonathan Gall to help coordinate this and to publicize. We got many on the radio. Unfortunately, we couldn't participate in CTV on Shabbos Friday, but thanks for all the publicity through the Suburban and for putting this together. So now I have the pleasure of introducing Alexandra Cohen, who is a Med 2 student at McGill University. She's also the Vice President of medical education. I was going to say teaching, but we're not teachers anymore, we're educators, and they're not students, they're learners, according to the technique. For it's the MSS, which is the McGill Student Society. We deal with the MSSS, which is the Ministry of Health, which is far more frustrating. So Alexandra's going to talk about an interesting but somewhat at times controversial concept, which is why do women present a little bit differently with heart disease and how do they present?
Hi, so my name is Alex. As Dr. Edsky said, I'm a Med 2, and I'll be speaking about women and heart disease today. So I'd like to start with a case. This is a fictional case, but it's based on many true stories out there. Mrs. Smith is a 65-year-old woman who presented to the ER this morning. Starting 4 days ago, she began to feel short of breath when walking up flights of stairs. She described feeling profound fatigue and nausea. She was breaking out into cold sweats, and she started experiencing some generalized arm and back pain. At the time, her husband urged her to go to the hospital, but she insisted that she just had the flu. She said, "I'm having heart palpitations because being sick makes me feel anxious." And in her mind, there's no way that this could have been a heart attack. You know, there was no sudden onset, no crushing chest pain. And either way, cardiovascular disease is for men, right? Out of curiosity, can you raise your hand if you believe that more men than women have cardiovascular disease? I primed you a little bit by giving you the title of this presentation, so I'm not surprised. But in the general population, I would say most people believe it's more commonly experienced by men than women. So I'd like to break that down a bit. Apologies to the people over there who can't see my graph, but essentially it divides cardiovascular disease by age and also by sex. So for those who can see it, the blue is for men and red is for women. As you can see, between the ages of 20 and 59, it is slightly more common in men than in women. That's because at that time, women are under the protective influence of estrogen. Oh, sorry, something weird just happened on the computer. There we go. So at that time, women are under the protective influence of estrogen. However, when they hit menopause and their estrogen goes down, that protective influence goes away. Between the ages of 60 to 79, you can see that they're completely equal, the rates between men and women. And then between ages of 80 and higher, women actually surpass men and are more likely to experience cardiovascular disease. If I haven't convinced you yet, I have some stats to back it up. According to Statistics Canada, around 1/3 of Canadian women die from heart disease. In fact, cardiovascular disease is the global leading cause of mortality for women. If you look just at the Western world, it's #1 in the United States and #2 in Canada, just below malignancies. More women die from heart disease than from breast cancer, cervical cancer, and ovarian cancers combined. Yeah. 2/3 of the women who die from cardiovascular disease actually had no previous cardiac symptoms. And mortality after a heart attack in women is greater than that in men, when you look at 1-year mortality and again at 5-year mortality. And in fact, at the 5-year mark, women are also more likely to suffer from heart failure and from strokes. So going back to the case for a moment, one of the main problems with Mrs. Smith is that she did not want to go to the ER because she did not believe that she was having a heart attack or that anything serious was happening. And that's because cardiovascular disease is a lot harder to diagnose in women. They present quite differently. More women than men having a heart attack actually present without that characteristic chest pain. So first I'll just break down the common symptoms that can happen in a man or a woman who are having a heart attack. Crushing chest pain, cold and profuse sweating, nausea, pain that radiates to the neck or down the left arm, and a sudden onset of symptoms. So if I were to describe a patient to you with those symptoms, I think everyone here would pretty much say that sounds like a heart attack. However, women can also experience a series of atypical symptoms, like Mrs. Smith did. That would include a profound sense of fatigue, shortness of breath, flu-like discomfort, a feeling of indigestion or heartburn, palpitations, back pain, and a feeling of generalized anxiety or impending doom, as some people like to describe it. And these symptoms usually are more slow and progressive, and they may come on over a couple of days. So it's no wonder that it's difficult to recognize when a woman is having a heart attack if they're presenting with the atypical symptoms. That's one of many reasons why women go undiagnosed. Also, some physicians may still be underestimating the prevalence of cardiovascular disease in women, or may not always recognize those atypical signs. Women actually comprise less than 24% of participants in all heart-related research studies. It's very male-dominated still. Women are being given less information than men, both pre and post a cardiac event. And women have been shown to be ignoring those early warning signs and delaying too long in seeking help. Actually, a recent study compared women to men in terms of how long it took them to go seek help when they were having a heart attack. The mean delay time in men was 16 hours. That's already pretty high when you're talking about a heart attack, but in women, the mean delay was actually 54 hours. So I'd like to conclude by talking about some recommendations that have been made by the American Heart Association in terms of how we can help improve this problem. Number one is to increase awareness of medical professionals about women's cardiovascular disease. We're actually doing a very good job with that locally. In my first year of medical school, I've already had a lecture on cardiovascular disease in women and how to recognize the signs. The goal in this is to improve primary and secondary prevention and also improve the outcomes, reduce that mortality rate. We also want to increase awareness in the community about women's cardiovascular disease, like we're doing now by speaking to all of you. The goal in that would be to improve symptom recognition and improve the rate of consultation in women. Finally, we need to include women more in research and also have some research that focuses more on female-specific cardiac issues. Thank you.
Some gasps in the audience when some of those stats were presented, and they're real stats. I said that I heard some gasps in the audience when some of the stats were presented, but that they really are stats. So we saved the motivational talk for last. Shashi Portnoy is a cardiologist who trained with us at McGill University, and then worked part-time with us as well. And now she is a clinical cardiologist in 2 places. Actually, probably more than 2 places. You're 2 right now. So she is the co-director of Portnoy Medical, and also is a cardiologist at Hôpital Notre-Dame. You should know that 100% of the full-time cardiologists at Notre-Dame are actually Jewish, and she's one of the 2.
We have a growing team. So, thank you everybody for those interesting talks. We talked about a lot of heavy things, and I hope to end with something a little more positive that we can all do to prevent some of those heavy things we discussed. So I want to talk a bit about exercise today. I'm going to give you a little bit of basic scientific data, and then go over some of the benefits, some of the Canadian guidelines regarding exercise, and then how do we address exercising after heart attacks? What do we do? Can you all hear me? Yes? So, exercise really is the best medicine. So to prevent a heart attack, take a baby aspirin every day. Take it for a run, take it to the gym, take it for a bike ride. So I'm going to tell you about a couple studies. There's a really large, very classic study that's described called Intra-Heart Study. So this is a study that really wants to look at the whole world. So it was a global study of 52 countries. Okay, and they studied 15,000 people with heart attacks, and they took another 50,000 controls. And what they were trying to understand is across gender, so taking gender aside, taking ethnicity aside, taking age aside, taking geographic region aside, what are the major risk factors for heart disease? What are the things that we can do to prevent heart disease? And they identified 9 risk factors. So smoking, cholesterol, hypertension, diabetes, abdominal obesity, psychosocial factors, things like depression, stress, major life events, locus of control. They actually identified daily consumption of fruits and vegetables, so we eat fruits and vegetables, and regular physical activity. And all of those were significantly related to heart attack. The first few were obviously if you don't smoke and have your cholesterol controlled, and at the end if you are more active and eat a more healthy, heart-healthy diet. And modification of these risk factors can really account for about 90% of attributable population risk, so things that we can do to prevent premature heart disease. So this was a little study done also about 18 years ago, all in men, 6,000 men, another backing up what Alex has told us about underrepresentation of women in scientific studies. But about 6,000 men, and they did sequential men, so 6,000 men who were referred for exercise testing for all different reasons, and they followed them for 6 years, plus or minus 4. And they followed them up, and after they adjusted for age, essentially their peak exercise capacity, so the more they were able to do, which we measure in what's called METs, or metabolic equivalence, which is essentially how much, it's a measure of your exercise intensity based on how much oxygen you're using. So the exercise capacity that one had was the strongest predictor of death among people without and with cardiovascular disease. So they found that for each one MET, so a little more fit that you had a reduction in 12% in mortality. So it just shows how fitness can be so protective. This is my last scientific table to show you, and I actually love this table. If you look at the dark gray, okay, the dark gray bars are showing the more fit, so more than 8 METs. The light gray bars are less than 5 METs. So if you look across high blood pressure, COPD, diabetes, smoking, obesity, or high cholesterol, the more fit you were, the more you were in the dark gray bars, the less your risk of death. So taking any disease, or these diseases, or most diseases, being more fit will be more protective. And we see that also when we talk about going for surgery. When we do preoperative assessments, we look at somebody before going for surgery. A big part of it is how fit are you? What is your functional capacity? What can you do? And the more fit you are, the better the outcomes. So giving you some of that scientific background hopefully will help to do our biggest challenge, which is then making behavioral changes, which is a lot harder than taking medication. So governments realized we need to get people moving, and the Canadian government came up with some guidelines towards healthy lifestyles. So the Canadian Physical Activity Guidelines for 18 to 64 basically suggests 150 minutes of moderate to vigorous intensity exercise per week. And it needs to be within 10 minutes or more. So when I run around the hospital, it doesn't count, because it takes me about 5 minutes from my office to the ER, so I don't get to count that in my 150 minutes. And they also suggest adding a little bit of muscle and bone strengthening activities, at least a couple days a week. And if you talk about what's moderate, so moderate are things that will make you sweat a little, breathe a little harder, brisk walking, bike riding, and vigorous is more things that you can be out of breath and probably can't carry on a great conversation, like jogging or cross-country skiing is pretty good too. And in case you thought, well, those were 18 to 65 and I'm over 65, so I don't have to do as much, the guidelines for over 65 are actually the same in terms of 150 minutes. What they do add, though, is that if there is poor mobility, then you should do things that enhance your balance, prevent falls. That's certainly encouraged. So, why should we do that? So if you're active for 150 minutes per week, it can help reduce the risk of premature death, heart disease, stroke, high blood pressure, certain types of cancer, type 2 diabetes, osteoporosis, overweight and obesity. It can lead to improved fitness, strength, mental health, morale, self-esteem, and can help to maintain your functional independence, maintain mobility, improve fitness, improve and maintain body weight, and maintain bone health and mental health and feel better. So there's a lot of good things about exercising. So to give you a context of how far we come, does anybody know who this is? This is a good audience. I gave this talk to some med students. I got like blank stares. So yes, this is President Dwight Eisenhower, 1955, and he's in a wheelchair because he suffered a heart attack in his office. And after a heart attack, what was suggested was bed rest, and he was in armchair therapy. My father-in-law was telling me that when he was an intern, my father-in-law is here, Dr. Portnoy, when he was an intern, what did people do? They had 6 weeks of CCU monitoring where they were isolated to a bed for 6 weeks of bed rest. So things have changed, and what we say now before and after a heart attack is it's time to get moving. So I want to talk to you just for a couple minutes about cardiac rehab and prevention, which is essentially a multidisciplinary program that we target multiple levels of modifiable behavior. So a comprehensive program would address a lot of things. Health, behavioral change, and education. We would look at managing cardiovascular risk factors. So physical activity, exercise, we'd actually do a stress test, give a personalized exercise prescription, and then ideally, if the budget can afford it, do an exercise program with an individual person. We'd also have a nutritionist, dietitian, assessment, counseling on heart-healthy diets, smoking cessation, psychosocial and health and stress management, looking at depression and anxiety, dealing with a substance abuse, distress about post-heart attack, how to deal with things after, how you feel, isolation, sexual dysfunction. We'll also address medical diseases like hypertension, sleep apnea, dyslipidemia, diabetes. So you're really getting a very broad, multidisciplinary approach, a whole person approach, and very effective programs. And of course, we work at optimizing medication, making sure that people are reaching the right goals that we need in terms of the doses and on the right meds for the individual. So this little slide, this is actually the University of Ottawa has a beautiful cardiac rehab program, and I just pulled up their slide because I want to draw your attention to the green bubble, which essentially tells us that cardiovascular rehab, after taking away the initial treatment of a heart attack, so will actually decrease mortality by about 27%. So that's a major benefit that we can hardly say for, there's very few things in medicine that we can really attribute that type of mortality benefit to. Mark Eisenberg did a big meta-analysis, which I decided not to add because there's a lot of numbers, but showing that all-cause mortality benefits of cardiac rehab. So it's a really great program and is across all our guidelines, Canadian, American. It's what we call a class 1 indication. So this is not what is a good idea, but what should be done is standard quality of care is to have a really strong cardiac rehab program because it does save lives. So I hope in the few minutes I'll be able to give you a bit of the benefits of exercise, both as prevention and therapeutic strategy. And exercise really is the underprescribed and underfilled prescription. Probably much harder to do than take a pill, But I hope that some of what we've spoken about has given you a bit of motivation to find the time. People often ask me in my office, what's the best exercise? The one that you like and the one that you'll do. And when's the best time? Whatever time you put it in your iCal or your journal if you don't have an iCal. So decide it, plan it, and get moving. So thanks.
That was great. Just for somebody sitting in the front row, Carnutzel is not a vegetable. Although Barack Obama during his first term as president Barack Obama during his first term as president in bowing to one of the special interest groups did classify for the purposes of U.S. high schools that pizza is a vegetable. So that way they can continue serving it in the high school cafeterias. They said, well, you know, as a quarter of a tablespoon of tomato sauce and that is a vegetable. So let's take questions.
Prolapse, what are the symptoms and what is it?
Mitral valve prolapse. So the question is unrelated to exercise. So mitral valve prolapse, what is it and what are the symptoms? So everybody who's ever had me as a teacher knows the answer to every question, so it depends. There are many different symptoms that are attributable. First, what is mitral valve prolapse? So normally the mitral valve, as Dr. Moss described, okay, I'm going to switch. As Dr. Moss described, the mitral valve has two components to it. It's actually named after the bishop's mitre, which has a pointed hat, which has two components to it. So normally the leaflets come together. Leaflets come together and seal to block the blood from going backwards from the ventricles it's pumping back up into the atrium. So sometimes they bend too far back and they prolapse back. So when they prolapse back, there's a gap between the leaflets, so some of the blood squirts backwards instead of all going out the aortic valve to the rest of the body. So mitral valve prolapse is the bending backwards of the leaflets. And you can have no mitral regurgitation with it, you can have mild mitral regurgitation, you can have severe mitral regurgitation. And severe mitral regurgitation, ultimately over years, can cause the heart to get bigger, and then floppier or lazier, and can cause signs and symptoms of congestive heart failure, which is really shortness of breath. Some people, there has been the description of what's called the mitral valve prolapse syndrome, which is atypical chest pains, these weird, strange pains that you can get. Some people get palpitations with it, but really in terms of the significant mitral valve prolapse that we have to do something about, it's when we have these big bending backwards, a big leak, and we have sensitive markers of when it's time to act on it. And the acting on it right now is sending them to Dr. Moss for a robotic repair. I think actually Rabbi Frumlich had a question.
An exercise question. I've heard recently a lot of talk about the 10,000 steps a day. Is there any validity in getting them without actually breaking the sweat, just making sure that one actually takes 10,000 steps a day? Is that of actual benefit towards heart health?
Definitely there's a benefit to achieving more steps in a day. To achieve maximal benefits, you do want to have at least a moderate intensity exercise, but I'd say that any form of moving is good, and also to each person is a different level, right? So somebody that's more fit can do more, and somebody who's unfit, well, just start slow. So certainly there is data. The 10,000 is not just a number. There is some data. It's a little out of my expertise, but there's definitely data to that, and the more the better. And any type of exercise is good. Higher intensity will lead to more cardiovascular benefits, but you need to start somewhere. So any intensity is better than none.
I would say, though, it doesn't count if you attach your step counter onto your dog and have it run around in the backyard. Yes?
I'm an avid non-smoker, but I was curious to know, what is the difference between cigarette smoking and marijuana effect on our heart?
We have an expert on smoking and smoking cessation, Dr. Mark Eisenberg.
So look, I take care of a lot of patients with, they have heart attacks, and we open up their arteries, and then we see them in clinic, a month later, and we ask them, we ask them in hospital as well whether they smoke, and often I get, I smoke marijuana, I don't smoke cigarettes, is that okay? And so I think my answer is, I think marijuana is safer than smoking conventional cigarettes. Conventional cigarettes are very, very bad for you. There's evidence that smoking marijuana is not good for your lungs. We don't have any evidence right now that it's bad for your heart. We wouldn't advocate that you smoke it, certainly not operate a motor vehicle with it. We have, they just obviously they just legalized marijuana in Canada, and the Canadian government's put out a lot of grant money. So we were recipients of $100,000 to do some research on marijuana. So there's a lot of concern about it. But big picture, marijuana is much safer than conventional cigarettes in terms of cardiac. You want to say something, Stan?
I just want to say that it's a little bit misleading because it depends on if people smoke marijuana the same way they smoke cigarettes, like 20 a day, they would have no brain. For some people,
I'm talking in terms of cardiac health, right? So a pack of cigarettes in Canada, it's 25 cigarettes in the U.S., it's 20. I don't think anybody smokes 20 joints a day in Canada, but there probably are people like that. But we know that conventional cigarettes cause lung cancer and chronic obstructive pulmonary disease. And you probably can get that as well with marijuana, but you'd have to smoke a much greater quantity than the average person does.
I'll just add that in terms of prevention, smoking cessation is probably the #1 risk factor that we can modify to decrease recurrent heart attacks and heart attacks. And so if there's any risk factor you were to address, I'd say smoking is probably your best bang for your buck, but of course we have to look at the big picture.
Question from the back?
6 years ago, I suffered a cardiac arrest. What is the difference between a heart attack and a cardiac arrest?
So the question is, what is the difference between a heart attack and a cardiac arrest? So they can be linked, or they could be completely separate. So a heart attack is a sudden blockage of a coronary artery, which causes the heart muscle distal beyond that blockage that would normally get blood flow from that artery to not get blood flow and to stop working. Now, what can trigger what happens sometimes, usually these people don't present to the hospital because they die suddenly at home, is from that lack of oxygen, the heart develops, we heard that question, what is ventricular fibrillation? So it develops ventricular fibrillation. So ventricular fibrillation, within seconds, the heart stops being able to pump effectively, and then it can't provide blood and oxygen to the rest of the body. So that's where you have to start your CPR, and you have to defibrillate, give the shock quickly. So a cardiac arrest is when the heart stops and you have to get it started again. So thankfully, within the hospital or within people that we see, it's quite rare to have a cardiac arrest in the setting of a heart attack. But in fact, one of the biggest lifesavers in terms of cardiac care was the founding or the formation of coronary care units, which only started in the 1960s, late 1960s or so. So as a result of that, when people would develop this ventricular fibrillation, they had defibrillators and they were able to respond very quickly, because the determinant of survival is how quickly you can defibrillate the heart and get the heart beating again in a coordinated fashion.
Jack, say something about it?
Can you tell me what age?
Sorry, just one quick point for cardiac arrests. Cardiac arrests can be due to a heart attack, to a myocardial infarction, and those are ones that are perhaps least likely to come back again because they had a sudden cause that was fixed, and hopefully it won't happen again. There are other causes of cardiac arrest, and I don't want to go into all of them. Many of them are electrical, and they require special treatment depending on the cause.
Can you tell me what HC